Respected judges and dear friends, a fine good afternoon to you all. Today I'll be talking about my study. It's a study of optical coherence tomography parameters in diabetic retinopathy. There is an emerging body of evidence which suggests that diabetic retinal neurodegeneration precedes microvascular complications in diabetes, and it can be quantified by measuring the retinal layer thickness. The rationale for my study is, if we can prove that if there is a thinning of retinal layers, it constitutes a great evidence that diabetes accelerates the age-related loss of ganglion cell inner plexiform layer. And indeed, neuropathy occurs before vasculopathy. Materials and method. My study was conducted in the Retina Clinic, Department of Ophthalmology, Government Medical College, Thrissur. It was a hospital-based cross-sectional study. Study duration was for a period of 1 year. My study population include patients with type 2 diabetes mellitus and age and gender matched non-diabetic patients attending the ophthalmology OPD. Inclusion criteria. Patients were divided into two groups. That is, group 1 include diabetic patients. They may have no diabetic retinopathy. They may have mild diabetic retinopathy or moderate diabetic retinopathy. And the group 2 include non-diabetic patients. They were age and gender matched. Exclusion criteria: patients not giving consent, not cooperative patients, extremes of age, changes of cystoid or spongiform macular edema on OCT, advanced diabetic retinopathy changes, who have undergone cataract surgery, history of macular laser photocoagulation. According to the study conducted by Hyung-Bin et al., the sample size was detected to be 30 eyes in group 1, that is patients with diabetes, and 30 eyes in group 2, that is non-diabetic controls, and a total sample size of 60 eyes. Study procedure: after an informed written consent, detailed history and complete ophthalmological evaluation was done. Heidelberg Spectralis spectral domain OCT machine was used to measure the thickness of the retinal layers. Inbuilt Heidelberg Spectralis auto-segmentation software was used to identify the ganglion cell inner plexiform layer and inner retinal layer thickness. This is the auto-segmentation software we used. The measurements were taken 1.5 millimeter from the fovea. Statistical analysis was done using chi-square test and Mann-Whitney U test. Coming to the results, the demographic showed that age and gender was indeed statistically comparable between two groups, and the mean duration of diabetes was 7.6 years. And in group 1, there were 16 patients with no diabetic retinopathy, 12 patients with a mild NPDR, and 2 patients with moderate NPDR. Now coming to retinal layer thickness, we saw a drastic change in the retinal layer thickness between the two groups. Compared to the group 1, that is non-diabetic controls, the ganglion cell inner plexiform layer was 92.3. The average was 92.3 in group 2, that is non-diabetic controls, compared to a staggering low 76.6 micrometer in group 1. Similarly, inner retinal layer thickness was a 247, a robust 247 in group 2 compared to 220 micrometer in group 1. Discussion. So, a significant reduction in the GC-IPL and IRL thickness were noted, thus confirming that diabetes is indeed an accelerating factor for retinal neurodegeneration. My study is in agreement with Hyung-Bin et al. Study, which showed progressive thinning of GC-IPL layers. Eliot et al. Confirmed progressive inner retinal layer thickening preceding the clinical stages in diabetes. This is a short diagram to show you what is happening in diabetic retinal neurodegeneration. There occurs various pathways resulting in oxidative stress, glutamate excitotoxicity, finally resulting in neuron death and glial dysfunction. Conclusion. Ganglion cell inner plexiform layer and inner retinal layer thickness are markedly less in patients with diabetes compared with the normal controls. So, OCT can serve as an important predictive tool in the detection of early diabetic neuronal degeneration. Limitations of my study include an absence of metabolic correlation with retinal layer thinning, a small sample size, and confounding factors like hypertensive retinopathy. These are my references. Thank you.
Yeah, that was a good presentation.
Thank you, sir.
How did you decide on the sample size?
It was deducted statistically from my parent study, which used about 132 patients. It was a prospective study. So from that, when we extrapolated into our settings, we got 60 eyes.
Okay, you used a formula based on the previous one, or you just use the same sample size that they used?
Formula based statistically
Okay,
deducted.
Okay. Why did you exclude macular edema from your?
I want to, the study's aim was to see early diabetic changes, that is before maculopathy, vasculopathy sets in. We wanted to see whether there is neuronal degeneration in diabetic patients compared to non-diabetics.
So vascular changes would be there in diabetic retinopathy.
Yeah.
And you included them in group 1.
Only where the macula was there is no macular edema.
Yeah, that's my question.
Yeah.
So why did you exclude macular edema but did not exclude diabetic retinopathy?
Macular edema, we were looking for the macular layer GC-IPL thickness.
Yes, correct. That's what I wanted. Thanks.